Let us have the second case by one of my very close friend, Dr. Dutta. He is an endocrinologist, DM endocrinologist, presently working in Dwarka, and he was associate professor at my institute only. Very close friend, a wonderful speaker, and let's go ahead.
Thank you, Dr. Pulinji. It's wonderful to have you here. Welcome to all the faculty and all the distinguished delegates. It's great to meet you all face to face after 2 years. Well, my job here is to handle a very difficult scenario which we see not so uncommonly in our practice. We have a lady here, 16-year-old lady. Her TSH is more than 100, but the difficult part is she's already taking 200 micrograms of levothyroxine. So what on earth is happening? What are we missing here? So before going to the patient per se, let us review some literature. This is a study done by Dr. Deepak. He is a part of the SPEED group. And here we see what he tried to do, the Indian data he generated regarding severe primary hypothyroidism. So we define severe primary hypothyroidism as TSH more than 40, compared to those who had so-called the non-severe primary hypothyroidism, TSH between 5.5 to 40, and those who had subclinical also. So what they found that in terms of symptomatology, weakness and breathlessness were two very common symptoms seen in people with severe primary hypothyroidism, like in our patient. In signs, what is very important is that delayed tendon jerk. We have stopped examining our patients. It's time we start again. A delayed ankle jerk or knee jerk is a very specific marker of severe primary hypothyroidism. And also, these patients will have carpal tunnel syndrome, is very common in severe primary hypothyroidism. Now, this is another data coming from RML Hospital. Here we evaluated the profile of presentation of juvenile hypothyroidism. So our patient is a juvenile 16-year-old girl. So what we found that in Indian setting, the most common presenting feature of juvenile hypothyroidism is the short stature. Nearly half of these kids had short stature. So if you have a hypothyroid child, so in our child, we should look at the height percentile. If the height percentile is less than 2.5 standard deviation, or it is less than third percentile for the age, I think she is having long-standing hypothyroidism, so that is something serious issue, need to be worked on. If her height parameters are normal, she has grown normally, means this is a transient thing, this is a recent onset thing. A lot of psychosocial factors, again, we need to look at. So approach becomes different in a short hypothyroid girl as compared to a normal height hypothyroid girl. Now let us look at the awareness from patient parts. So again, I'm quoting Dr. Deepak Khandelwal here. This was a study done in 250 odd people living with hypothyroidism in Delhi. They were all educated graduates or postgraduates. So in spite of having a good level of education, there was very poor understanding about how to use thyroxine in our clinical practice. Only one fourth, not even half, 1/4 of the patients actually knew they had to take thyroxine empty stomach and not take anything for the next 1 hour, or else it gets destroyed. The handling issues, how do we store the bottle of thyroxine, not to keep in kitchen, not to keep in warm areas, away from sunlight. These were not known even to the best of educated people. So we need to do a lot more in improving good clinical practices with regards to handling the thyroxine preparation. So coming back to our child, to the young lady here, so what we do? So it's a rare thing, it's a difficult condition. So we need to first discuss with the parents, family members who have come with the young lady, and then talk to her alone. The most common cause of need for high dose of levothyroxine and TSH going bonkers very high is poor compliance. That is the first, second, and third most common cause of such a report. So talk to the patient privately. Is she missing the tablets? Any stress, anxiety, exam? People have phobias or fears of thyroxine. Some feel that thyroxine causes bone mineral loss. A lot of women ask us, Doctor Sahab, thyroid ki goli khane se meri haddiyan kamzor ho jayegi. So all those fads, social fads are there. We need to look into and why, what is the resistance to taking thyroxine. Then discuss about the storage, handling, keep the bottle tight, away from moisture, take it empty stomach. People who work night shifts, so they might be having a cup of coffee at 3 or 4 in the morning and maybe taking thyroxine only at 6 in the morning, only 2 hours gap. So we always tell, don't take anything for 1 hour after taking thyroxine. It is even important to highlight, don't take anything in the previous 5 hours. We assume the patient would have slept for 6 to 7 hours. So we don't tell that to our patients. So these things also help us in reducing the need for total daily dose of thyroxine. If we find psychiatric issues, compliance issues, I think we need to take the help of our neuropsychiatric colleagues. Also, coming from Delhi, I think obesity is very common here. So we must realize the dose of thyroxine is 1.6 micrograms per kg body weight. So in a person who weighs more than 100 kilos or even 125 kilos, they will need a very high dose of levothyroxine to control their hypothyroidism. So that the weight also has to be taken into account. So because of compliance issues, a lot of hue and cry came from the industry about weekly thyroxine preparations. So the logic is, when we pop in a pill of thyroxine, the effect lasts in the body for 7 days. So what if we take all the 7 tablets on a Sunday, or you have a preparation which contains 700 micrograms of thyroxine, you just pop in one pill, what would it do? Yes, it works. It helps in controlling hypothyroidism, but the long-term effects are not so great. This is a meta-analysis which we published, taking into all the randomized control trials across the globe, which evaluated weekly versus daily thyroxine. What they found that the overall control of TSH value after 6 weeks or 12 weeks is inferior. TSH continues to be very commonly higher as compared to daily thyroxine intake. Another problem is that the first few hours after popping in that 7 days dose of thyroxine, the cardiac changes are seen. Echocardiographic changes are seen in terms of relaxation of the ventricles. So not a great idea, especially this weekly therapy is recommended in extremes of ages, in kids or elderly where Alzheimer's disease, memory issues, people forget pills. So directly observe treatment once a week thyroxine de diya. So even in the people whom this is recommended, they are actually at the highest risk of complications. So discuss with the patient if she is using weekly thyroxine preparation. Strict no. If we come back to daily thyroxine, the need for thyroxine dose would come down drastically. Now, very common in today's scenario is the endocrine labomas. So what are labomas? It's a lab error. The patient doesn't have anything wrong with himself or herself. The lab report creates mess for us and the patients. So with the advent of all these whole body checkup packages, we are routinely seeing patients with TSH of 6, 7, 8, and they come to us, Doctor Saab, karna kya hai is TSH ka? They were apparently feeling fine. They just thought of getting a whole body checkup done. So we do nothing for them. Mild subclinical hypothyroidism with no symptoms, need no treatment. Most often these patients are overweight or obese. You lose the body weight, your TSH comes down. Another big problem is the use of biotin supplements. So biotin supplements are very common for hair fall, used by dermatologists and other different specialties. The problem is all the hormone assays, they use streptavidin. Streptavidin is a derivative of biotin. It is used as a ligand for antigen-antibody reaction to measure the hormone. So anybody who is taking biotin supplement, the TSH is going to come falsely high, sometimes even very high. So ask the patient, are you on any multivitamin which contains biotin? If so, please stop it for at least 10 to 14 days and repeat the TSH. We need a gap of at least 10 to 14 days for it to wash out before we repeat the hormone assay. So next, what we do in our patient, so we have a TSH more than 100. Look at the total T4 or free T4 levels. Ask for the hormone levels. If the hormone values comes low, we know it's a log linear relationship. If the T4 is low, TSH is supposed to be very high. For every unit change in T4, you have 10 times the change in TSH values. So then either there's a clear-cut compliance issue, the patient is not telling, we again need to further drill the patient and the family members find the issue. The problem comes when the TSH is high, like more than 100, and the T4 comes normal, or may rarely, even the T4 may come even high also. Then that's a problematic area. So that means the patient has sufficient levels of circulating thyroxine. For some reason, the TSH has gone bonkers. Then this biotin comes up. History of pets in the family, many times heterophile antibodies are there, anti-mouse antibodies, anti-rabbit antibodies. They cross-react with the TSH assays and the TSH comes falsely high. Beyond this, I think we are talking of extremely rare conditions like TSH secreting pituitary tumors where the TSH is very high and the tumor is making excess autogenous TSH and that's driving the thyroid to make more hormones. Very, very rare. The prevalence is around 1 in 1 lakh population. I have seen only 2 patients of TSHomas. Or thyroid hormone resistance where the TSH is forming but the gland says I am not going to respond. Very simple. So TSH, the pituitary needs to make extra amount of TSH for it to stimulate the gland to make hormone, what we call the thyroid hormone resistance. So these are 3 kids. I would like to highlight how they present to us. So when we talk of thyroid hormone resistance, the beauty is the resistance is not uniform at different parts, all over the body. The resistance may be more at the level of thyroid gland or at the level of liver or at the level of pituitary. It can happen. It's differential resistance. So these kids, they usually come with short stature. Some of them may be hyperkinetic in spite of having a high TSH. Some of them may have attention deficit disorders, and goiter is very common. Look at their growth percentile. Short stature is very, very common in such kids with thyroid hormone resistance. So they have high, as you see here, high circulating levels of T3 and T4, and the TSH should have been suppressed. It is not suppressed, it's actually high in one of the child, as high as 14.6. What is important to realize is, this is because of mutation in thyroid receptor beta. This test is not available in our country. So how do we diagnose? Very simple, you do ferritin and SHBG, very cheap, easily available test. In hyperthyroidism, in true hyperthyroidism, because of high levels of T4 coming from thyroid gland, they stimulate the liver to make more proteins. So SHBG and ferritin shoots up like anything. Because of resistance at the level of liver, even with high circulating levels of T4 here, the ferritin and SHBG levels are normal. A very simple, useful test to diagnose thyroid hormone resistance and differentiate it from true hyperthyroidism. Not seen in our patient, just wanted to highlight to complete the picture of thyroid lipomas. Important, drugs, drugs and drugs. So we tell our patients to take it empty stomach. We also need to tell them, please don't take it with any other tablets. Most commonly people are taking antacids like proton pump inhibitors. If they are taking thyroxine with it, it will delay the absorption, it will inhibit the absorption. So if people have to use antacids, tell them to use before lunch or dinner, not in the morning. If they are using calcium supplements, iron supplements, they should keep at least 4 to 6 hours gap between calcium and iron supplements and thyroxine, or else it will degrade the thyroxine. The patient will need very high dose of thyroxine to control a simple plain primary hypothyroidism. Take a history of epilepsy. If they are on anti-epileptics like carbamazepine, phenytoin or phenobarbital, they are CYP enzyme inducers. The hepatic turnover of thyroxine goes up, and again these patients are going to need a very high dose of thyroxine to control primary hypothyroidism. Use of estrogen contraceptive pills does the same job. People need higher dose. So drug history is very important. As a rule, take thyroxine empty stomach, and if you are taking with it, don't take any medications. People have food fads. They say कि डॉक्टर साहब ने बोला कुछ नहीं लेना है, 1 घंटे खाना नहीं खाना है, but they will taking their apple cider vinegar for weight loss. Very popular from Facebook posts. They will be taking some jeera pani and nimbu pani and what all. So they also interfere with thyroxine. So nothing means nothing. Just a plain glass of water will do the job. So we have discussed analytical issues. We have discussed pre-analytical issues. So these things, and rarely if you see, if a TSH is more than 100, like in our young lady, what happens? Very high levels of TSH can sometimes cross-react with the LH and FSH receptor. We know the alpha subunit is same for LH, FSH and TSH. That can lead to huge enlargement of ovaries, as we see in this young lady, and they are sometimes diagnosed as ovarian tumors. You just correct the hypothyroid properly and these ovarian tumors disappear. What we call is the von Wieck-Grumbach syndrome. So again, these kids are also very short. They have pseudo-precocious puberty also. So again, in our patient did not have any short stature. She did not have any ovarian masses. So I think in our patient, we are probably dealing with something more likely to do with non-compliance. He doesn't have the other ancillary features of chronic, long-standing, uncontrolled primary hypothyroidism. So these kids, and if a person has TSH more than 100, the TSH has to come from pituitary. That means the thyrotrophs in the pituitary needs to work really hard, and so you will have a hyperplasia of the pituitary. You can actually do an MRI, you see an enlarged pituitary like a pituitary adenoma. So these kids on chronic uncontrolled hypothyroidism can have even bitemporal hemianopia. They can have headaches because of enlargement of the pituitary, putting a pressure on the tentorium. So those things were not there. These are subtle markers which rules out anything grave happening in a child. So this child had a feedback enlargement of pituitary. You correct the hypothyroidism, the pituitary size normalizes. So most of the patients, 99 out of 100, you will be able to find the cause of non-compliance. In that 1 out of 100 patient, we find nothing, then you have to do a levothyroxine challenge test. You have to document that patient does not have any malabsorption issues. So take a history, simple history of gluten intolerance, recurrent diarrhea. Celiac disease can lead to a need for very high dose of thyroxine for primary hypothyroidism. We know that hypothyroidism is more common in people living with celiac disease. So how do we do a levothyroxine challenge test? Simple. You give the patient 10 micrograms per kg body weight of thyroxine. Normally we give only 1.4 to 1.6 micrograms per kg for replacement. Here giving nearly 10 times the dose. 10 micrograms per kg of levothyroxine or 600 micrograms whichever is higher, and you measure the thyroxine levels at 2 hours, 3 hours, and 6 hours, giving that such a huge dose of thyroxine. So you call the patient to your clinic, give it under your observation, make the patient wait there. So the cutoffs is this study done from IPHMER Calcutta, where the Indian data again which showed that if you see a rise in T4 levels by more than 0.4, free T4 levels of more than 0.4 nanogram per deciliter, you are ruling out malabsorption. So a 3-hour post intake of 600 micrograms of levothyroxine, if the pre-supplementation to post-supplementation free T4 levels increases by more than 0.4 nanograms per deciliter, you are ruling out malabsorption. Go and grill the patient again, alone or with the family members. So this is a very high sensitivity of 97% and a very good specificity of 80% in differentiating pseudo malabsorption from true malabsorption. So now this is a data which the SPEED group generated as a whole about the practices of managing hypothyroidism among doctors in Delhi, and a very encouraging data that most of the doctors were using branded good preparations of thyroxine. That is very important. With the advent of generic thyroxine, I think that is something which doesn't work great. It is difficult to make thyroxine. It's a biologic, it's a hormone. It is not a simple chemical like anti-diabetic agent or a metformin or glimepiride. So a very common cause of rise in TSH is use of generic thyroxine. Sometimes they come in strips also. So take the history, tell them even the branded thyroxine costs only 1 Indian rupees or 1.2, 1.3 Indian rupees per tablet. It's very cheap. Please use a good manufacturer branded thyroxine. That would really help in controlling a majority of patients needing such supraphysiologic dose of thyroxine with high TSH. So the take home message is the most common cause of such a picture in our patient is poor compliance. Look into the history of handling of thyroxine, intake of thyroxine, storage of thyroxine, and levothyroxine challenge test is there, but we need it very, very rarely in our clinical practice to rule out true malabsorption from pseudo malabsorption. Thank you so much.
Thank you, Dr. Dutta. You have very nicely told about the problem. You have told about the manufacturer problem. That makes me very happy.